please ensure that the pain that you're going to deal with is opioid responsive pain. Can anyone shout out a couple of pains which are non-opioid responsive? Anybody? If there is any pain that you can immediately think of which will not be opioid responsive. Anyone? Hello, can you all hear me?
Yeah. So, anybody has any answers for Dr. Vidya's question?
Dr. Vipin?
Neuropathic pain.
All kinds of neuropathic pain. That's a rather broad answer.
Pain.
Sorry.
Ma'am, pain due to visceral pain, especially due to the intestinal obstruction.
Okay.
Smooth muscle.
To some extent, then something that will just not respond to opioids, however severe that pain. The score will be 11 on 10, but it will not respond to opioids. Any particular kinds of pains that you all can think about? See, things like increased intracranial tension, when they come to you with that splitting headache, and then certain kinds of neuropathic pain, these will not respond to opioids. So right in the beginning, when you assess your pain, make sure that the trial that you're going to give is for a pain that would respond to opioids. And then also the role of adjuvants. Like some of you said neuropathic pain and the answer. So yes, neuropathic pain does not respond to opioids, but it's not always like that. Most of the pain that we see is a mixture of nociceptive and neuropathic pain. And so in those situations, we definitely use opioids. And opioids do have an effect on neuropathic pain, especially tramadol. You can use it in neuropathic pain. So it's not like opioids can never, neuropathic pain is never responsive to opioids. The role of adjuvants in pain management is very, very important because whatever we do, we might have to deal with pain with 2 or 3 different kinds of medication. We have to deal with the side effects. So adjuvants, along with our main pain medications, are very, very important. And I can never, I'd always like to say that role of disease-modifying therapies, because again, intracranial tension. Suppose you have a brain lesion and you've detected a brain lesion, the patient has come to you with splitting headache and vomiting. That moment in time, a whole brain radiation will be very, very important. So role of disease modifying therapies, it's not that if a patient has come into palliative care, we just completely negate disease modifying therapies. They go hand in hand. So many a times, like the role of gemcitabine in pancreatic cancer is mainly for quality improvement and bringing down the pain. So we can use chemotherapy, palliative radiation, especially for bone pain. Again, bone pain is a pain which does not respond completely to morphine. So these are all things that we need to consider because, like I always emphasize, morphine is not just a tablet. It is not just something you can write and give and expect that all pains are going to get cured. So assessing the pain, making sure it's opioid responsive, making sure you have the right adjuvants, adding disease modifying therapy wherever it is needed, and most importantly is dealing with total pain. And when we say total pain, what do we mean? We mean we are going beyond the physical. You have to assess the psychological impact, the emotional, the spiritual, all of these parts. Otherwise, your morphine will have no value. You can keep increasing the dose and the pain will not respond. So these things have to be taken in mind before this session even starts. Can I have the next slide, Rajlakshmi? So we are now at step 3 of the step ladder. We are going to talk about opioids. The WHO step ladder is something you all are familiar with. So as the pain is, we base it on the severity of the pain, and it always goes with the step 1 of the ladder. Next slide, please. Now this is a man at one of the expressions of chronic pain, completely upset, distressed, and suffering with pain, and really has no one around him. And he doesn't know what is happening. Next slide, please. So when this 56-year-old man with carcinoma of the larynx comes with pain around the neck, we have assessed it. It's a 10 on 10 pain. It's sharp. There is no radiation, so which tells us that it's more nociceptive. He has not been able to sleep. The pain has been there since the last 2 weeks. How will you manage? So now we have categorized this as a severe pain, which we are going to think is responsive to opioids. He's been taking something or probably nothing when he has come to you. So how are you going to decide how much morphine I'm going to start this patient with? We are going to start him on morphine. So how much of it this patient needs? Next slide, please. Next slide. So this is what happened to him after we gave the intravenous morphine trial. Can you just run the whole slide, Rajalakshmi, please? Yeah. So when we say morphine trial, what do we mean? Because morphine is one of those drugs which we do not give based on body weight. So when we do not give this drug based on body weight, we give it based on the need and based on the severity. So this patient had nociceptive pain, well deserving of morphine. It was a 10 on 10. But how do I start it? So when we want to give it as an intravenous trial, always have metoclopramide in hand before you start. Get an IV line or a subcutaneous route. Get an IV line and then give him metoclopramide 10 milligram. Follow it up with morphine 1.5 milligram at 10-minute intervals. So as we give this, we maintain a chart, which will be shown in the next slide. And in this chart, we assess how much the pain has responded after every 10 minutes. So suppose it was a 10 on 10. After the first 10 minutes, how much of the pain came down? And is the patient drowsy? These are two of the main things that we see. Next slide, please. So suppose we started at 10 o'clock. The patient's pain score was 10 on 10. We gave him 1.5 milligram or 1 ml of morphine. After that, we now at 10:10, the score was 7. We give a second dose of 1.5 milligram. Then at 10:20, the score has come down to 4. We give another dose of 1.5 milligram. At 10:30, the score has come to 1. Patient is still not drowsy. We stop there. So what have we done effectively in these 30 minutes? We have not decided, the patient has told us that 4.5 milligram of morphine. Next slide, please. The next slide, please. Yeah, that we gave him 4.5 milligram of IV morphine and he had good pain relief. Now, why did we give him this trial? Because he was so distressed with pain that we wanted an answer immediately. We wanted to know how much pain relief he has got and what dose can help him. So now once we have determined that 4.5 milligram IV morphine has given him good pain relief, how do we convert this into the oral dose? The next slide, please. The next slide, please. Yeah, so these are the timings for oral morphine. Usually we keep it at 6 a.m. When the patient wakes up, we ask him and tell him it's at 6 a.m., 10 a.m., 2 p.m., 6 p.m., and when he goes to sleep, which we write as 10 p.m. So these are the timings for morphine. It really helps, especially when you're seeing a lot of patients every day and you have to tell everybody something uniformly. Write out the timings for the patient, because till today, it's very rare that patients are given medications with so much emphasis on the clock. But morphine is one such medication. The emphasis on the clock is very important, because we need to tell them that if you don't take the medicine every 4 hours, your pain is going to come back. So this patient, we saw that 4.5 milligram gave him adequate relief. So the dose that gave him good relief with the morphine trial is the dose which becomes the 4th hourly dose of morphine, which means the closest in the tablet is 5 milligram. We have a 10 milligram tablet available. So we tell the patient, take half a tablet at 6 a.m., 10 a.m., 2 p.m., 6 p.m., and at bedtime, 10 p.m. And the most important is that last column, which says SOS, or we call it breakthrough pain, or we call it a rescue dose. Whatever the language, the emphasis should be that when you are giving the patient a 4th hourly dose, the same dose becomes the SOS dose, which means that suppose the patient has pain at say 8 a.m. or he has pain at 12 noon or at 4 o'clock. It doesn't mean he has to wait to take the tablet till 6 p.m. He takes an extra dose, and that extra dose is the same as the 4th hourly dosing. This is something we need to spend time and explain to the patient, because writing it will never help. And emphasize about the dose, tell them, and then suppose a patient is taking, we'll come to that later. Next slide, please. So we start with, and now in a busy OPD, or when you're seeing multiple patients, so many patients every day, it may not be possible to give an injectable morphine trial. So in that case, we give an oral morphine trial, plus the logistics of having the injection vial. If a patient feels better within 2 doses, what do you do with the rest of the morphine? All these are issues that we need to think about. And it's not so easy to procure injectable morphine. So in these situations, we give what we call as an oral morphine trial. So what we do is we start with 5 milligram. We break a tablet, half a tablet. I usually give it along with a Paranorm, tell the patient to take a Paranorm before and then give him the tablet. We give this to the patient and then tell him to we grade his pain and we tell him, you're telling me now that it is an 8 on 10. So I'm giving you this tablet. Could you please take it and come back to me exactly after about 35 to 40 minutes and tell me what your pain score is. If a patient is opioid naive, which means that he has not taken any opioid, he's not taken tramadol, he's not taken anything, he's just come to you first time in your OPD, we start with 5 milligram based on the severity. And for those who are already on tramadol, who are taking it 3 times and still the pain is not coming down, we can start with 10 milligram also. But in practice, it always helps to start low and go slow. So start with 5 milligram and assess the pain after 40 minutes. Next slide, please. So now we have Mr. X. He was started with 5 milligram 4th hourly and SOS. He was really happy for 2 weeks. He was pain-free. Now he needs 4 doses of morphine per day, SOS doses. So what shall we do now? So then we just start calculating. We say 5 milligram every 4 hours, which means he takes how many milligrams in a day? Anyone? Any answers? It's really nice. First of all, you're speaking to a screen, which itself is intimidating. So
30.
if you shout out some answers, sorry, yeah? 30, okay. So 5 milligram.
30.
Yes, 30 milligram a day. So now he needs 4 SOS doses. So that makes it how much? 30 plus?
20.
20. So that makes
30 plus 20.
50 milligrams a day. So next
50.
slide, yeah, next slide, please. So what shall we do now? Whenever 2 or more or PRN doses are taken every day, we start by increasing the dose by 30 to 40% every 2 or 3 days. Now this patient has taken 4 PRN doses. So which means he needs 50 milligram per day. So it's hard to tell the patient to take 7.5 milligram. So we usually tell them you can take 10 milligram, which is almost doubling the dose. So he takes 10 milligram and every 4 hours and then continues with 10 milligram SOS as he needs it. Next slide, please. So now how frequently would you give SOS doses of morphine and why? Why are we doing this? In no other drug do we tell the patient that just take as many SOS doses as you want, but make sure that you don't get drowsy and you're getting pain relief. Why do we do this? Next slide, please. That's because morphine is, yes, as you know, is one of the most important derivatives of opium. It is from the poppy. It is an alkaloid form from the poppy plant, Papaver somniferum. Next slide. And the pharmacokinetics of morphine is the reason why we can say these things. And what do we mean by that? It means how much of this drug is absorbed, how does it get distributed, how does it get metabolized, and how does it get excreted. Next slide, please. So when this drug goes into the GIT, it gets absorbed into the blood vessels and goes through the first pass hepatic metabolism into the systemic circulation. Next slide. So the metabolism that we see is mainly in the liver. There is a small part in the GIT in the kidney, and these metabolites are of two types. The active component, which gives pain relief, is the M6G, and the morphine 3-glucuronide is what is the other metabolite. Next slide, please. And where does this drug get absorbed when you take it orally? It is in the alkaline medium of the upper small bowel. It is a hydrophilic drug, so it takes time. It takes a little longer, but that is where the absorption happens. And if this drug is given either through the subcutaneous or in the intravenous route, it is readily absorbed. It is intravenous route. Next slide, please. Next slide. We can also give it by other routes. So one of the routes that we give is sublingual, buccal, and gingival. There are times when we have to actually tell them to crush the tablet, apply it in the buccal mucosa, because there is no other choice. The patient can't afford a transdermal patch, patient is too far away, you can't put in a subcutaneous line. So there may be logistic reasons, but if a patient is in pain, this is one more route that we tell them: crush the tablet, mix it in a little honey, and in fact just put it in the buccal mucosa. Though it takes time to get absorbed, it still can get absorbed. And the rectal mucosa is another way, another place where the drug can get absorbed. Next slide, please. Intravenous is an effective route, and because here the bioavailability, I think have the slides got jumbled for a bit? Rajalakshmi? Yeah.
Let me for a second.
Yeah, there's just, I don't mind if you show it like this, if it's okay for the rest, if this works better. Yeah.
No, ma'am. I think it's the correct order.
Yeah, now it's right. Okay, fine. So next is intravenous. Yeah, all right, good. So the intravenous route is one of the most effective routes. Why do we say that? Because the drug enters straight and you have 100% bioavailability of this drug. So the entire first pass hepatic metabolism, which happens when you take the drug orally, is eliminated. Next slide, please. So what do we mean by bioavailability? When we talk of bioavailability, we talk about how much of the administered drug goes unchanged into the systemic circulation when we give it orally. So how much of our drug actually goes in and produces the effect that we need. Next slide. So what gets absorbed in the body is not the same as the bioavailability, because morphine can be 100% absorbed, but what is available is only 20 to 40%. Next slide. So that is one more precaution that you need to take when you're giving someone a controlled release preparation. Now in practice, it's very easy to tell. It's rather difficult to sit with a patient and explain the 4th hourly dosing and tell them to take it every 4 hours and the double dose at night and the SOS and all these factors. So many times we see prescriptions which are controlled release morphine. Twice in a day, take 30 milligram, or twice in a day, take 10 milligram. There's nothing wrong about prescribing that. But what is it that you need to do before you go to a controlled release preparation? The first thing that you need to do is to actually count the amount of dose in 24 hours that the person needs. You cannot do that if you start with a controlled release preparation. So ideally, you always start with a short-acting morphine. You give them a 4th hourly dosing, wait for the pain to settle and stay there for a while. So give it a good 2 weeks or 3 weeks also. And once the patient's pain has settled with that dosing, then for ease of administration, you can convert that into a controlled release preparation by dividing the daily dose by 2 and giving them at 12 hourly intervals. But what happens in practice is there are many things we don't tell the patient when we give them a controlled release medication. The first thing that we need to tell them is this is not a tablet that you're supposed to break, because they are used to breaking a short-acting morphine. They have taken half, so they're used to breaking it. But a controlled release preparation, it's in the coating. So they are not supposed to break, crush, or chew this medication. And so many times, it may seem very foolish when I tell you this, but there are many times I see patients who come to us on Ryle's tube and who are given controlled release preparation, which actually does more harm than good. because the entire dose gets released at the same time. So they have spikes of drowsiness and spikes of pain. So be very careful when you choose your patient for a controlled release preparation. Make sure that they're able to swallow the drug and that drug remains there and gets absorbed. Whenever there is gastrointestinal hurry, there will be therapeutic failure. When the patient has a Riles tube, he cannot take a controlled release preparation. So these are things that you need to you need to be careful about while you're prescribing. Next slide, please. And what kind of preparations of morphine do we have? We have aqueous solutions, but I don't know about Kerala, but I think it's available only in Kidwai as far as the other states in the country go. And tablets is immediate release, and that is short-acting morphine and controlled release. Both of these are available. We get it in different strengths. You can get it in 10 milligram, 20 milligram, 30 milligram, and 60 milligram also. Then you have injectable morphine, which is 15 milligram in 1 ml. Next slide, please. Next slide, please. So now we have our Mr. X. He was on 10 milligram 4th hourly morphine for 6 months. He has suddenly come to you with excessive drowsiness. And then you examine him and you find out that he has a serum creatinine of 5 milligram per TL. Next slide, please. So what will you do with the morphine dosage? Any ideas from all of you? What would you like to do?
Reduce the dosage because renal clearance is impaired.
Yeah, renal clearance is impaired, but if you reduce the dosage, he may get pain. So what would you do then?
No change.
First thing you would do?
No change. No change.
No change.
No change.
Okay.
Because it is metabolizing in the liver.
Yeah.
And so there is no need to change if there is kidney dysfunction because the whole thing gets metabolized in the liver.
We were talking about the products which accumulate non-excretion. Next slide, please.
Even the
So this is the reason why the kidney is involved. It can get absorbed there, but the excretion of the drug is through glomerular filtration. And it is the M6G component which will accumulate in renal failure. So when clearance is decreased and half-life is prolonged, what we need to do first, even before we decrease the dosage, is increase the spacing of the time. Instead of 4th hourly, we will make the drug 8th hourly.
8th hourly.
So we make it 8th hourly. Now, ideally, in the Western world, in our textbooks and in evidence-based medicine, the first choice would be to switch the opioid and go either to fentanyl or to methadone. This would be an ideal choice. So if your patient and if the place where you practice and your patient can afford fentanyl and it works in that situation, you can change the opioid. You can switch the opioid to fentanyl or methadone. But in many situations, and especially because we use morphine forever for the patient till the patient is living, the affordability may be an issue. So the next best thing to do is to increase the spacing and make it an 8th hourly dosing. Next one, please. So now Mr. X was sent home, and this Mr. X was taking morphine 10 milligram 4th hourly. After 2 months, he was not able to swallow anything, even morphine. So now what would you do for pain relief?
Sublingual buprenorphine.
Now we also have to think, whenever we think in these lines, we have to think that this is not an immediate solution. This has to be a solution for the patient, which he should be able to follow even at home, or which we should be able to provide for him. Next slide, please. So we come to the different routes of administering morphine. When somebody comes to you with an inability to swallow, the first thing that we would like to do immediately is that we will have to admit him. We will have to give him an intravenous or a subcutaneous preparation. Next slide. And which brings us to the various routes of morphine. Again, in this patient, if he can't swallow, then we have to assess why he can't swallow. And in case we need to put in a Ryle's tube at that point in time, it can help, and then the medications can go through the tube. Or if he can't swallow due to some neurological condition, then why? And again, the answer to that many a times is a Ryle's tube, because this usually is what we see in oral cancers. After a point of time, there is complete inability to swallow anything. So we do need the help of a Ryle's tube for these patients. The other routes for administering morphine will include, besides the intravenous and the subcutaneous, like how I mentioned, the per-rectal route. One more area where I have found the per-rectal route very, very useful is in patients with CA anal canal or CA rectum. Many a times they give history of tenesmus, and it is so severe that nothing helps them. We give them any amount of oral morphine, they tell you, but that tenesmus is terrible. So in these times, it really helps to mix a little lignocaine and the 4th hourly dosing. Whatever is the 4th hourly dose I give them, I tell them to mix that dose in lignocaine and apply it per rectally. And somehow our patients do really well with that. They really feel a significant amount of relief with per rectal application of morphine at that time. Next route is epidural and the intrathecal. These are also routes by which morphine is given, though most of our experience is with the oral, per-rectal, intravenous, and subcutaneous routes. Next slide, please. So which again brings us to a point of choosing the right opioid. There are times when we do have to choose the opioid based not just on severity of pain, but because of other factors too. So now you have, so these are two examples that I'm giving you, which we will come towards after a few more slides too. So these are the two patients who we are talking about. One is Mrs. X. She is on 50 milligram morphine, which is 4th hourly. She has now come to us with severe pain. Your choices are injection pentozokin and an oral morphine tablet. So how are you going to manage? That is one patient. You have another patient, Mrs. N. She has breast cancer. She has brain metastasis. She has received radiation to the brain for her metastasis. She comes to you with just moderate pain over her breast. How will you manage? So why I have put in these two slides is, over the next few slides, we will just go through what are the receptors of morphine, where does it act, and then you could answer these questions. Next slide, please. So when we talk of opioids, it's a rather general term. It includes naturally occurring semi-synthetic and synthetic drugs which produce their effects. How do they produce their effects? They produce these effects by combining with opioid receptors. So this is how most of the time we explain to our patients, because many of the patients who come to us, they come and feel that, okay, pain has gone away, so my disease has gone away. So this is an area of caution when we practice pain medicine along with disease modifying therapy. We have to keep emphasizing to the patient that what I'm trying to do is trying to help you not feel the pain. So the drug that I'm giving you is acting on a receptor in your brain so that you do not feel the pain. It is not touching your disease. So this is something which helps when you talk to the patient. Next slide, please. So the various receptors on which opioids act are the mu kappa and the delta receptors. The next slide. So these are found in several areas of the brain, in the spinal cord, and in the peripheral nervous system. Next slide. And here we have various drugs. In the step 2, we have codeine and tramadol. These are the various opioids. When we talk of codeine, I don't know if it is available. Now we hardly get codeine over here. It is 1/10 as potent as morphine. It's mainly used as an antitussive, as an antidiarrheal. And it's a prodrug of morphine. So it becomes morphine when it goes into the body. 40% is the bioavailability. It acts in about 30 to 60 minutes. And the duration of action is within 4 to 6 hours. Next slide, please. It's used, like we said, we don't really use much of it in pain relief because we don't even get it. Cough suppressant and as an antidiarrheal. Next slide. Dextropropoxifen. Here it's 1/12 the potency of morphine and 6 to 8 hours is the duration, and it takes about 3 to 4 days for it to reach a steady state of action. Next slide. I'm just going over the opioids so that you, next slide, please.
Dr. Vidya, 1 minute, please. Somebody, those who are not speaking, please mute yourself. Otherwise, it will make noises. We can hear some noises. Dr. Shobha, I think you have logged on from 2 devices.
So you can log off from your laptop, I think.
Laptop. Let me just. I'll do it.
Okay, Dr. Vidya, you can continue.
Okay. Next slide, please, Rajalakshmi. Yeah. And tramadol, which is one of the most common step 2 opioids that we use, there are 2 ways it acts. One is it acts on the opioid receptors. The other thing it does is it has what we call as a tricyclic-like action. So it inhibits the reuptake of serotonin and noradrenaline. Yeah. Next slide. And it's 1/10 as potent as morphine and 1/5 orally. It is actually it's better to give this drug orally because the bioavailability of this drug is much higher orally than giving it parenterally. But it also lowers the seizure threshold. So one has to be careful. We usually don't give it to patients with brain metastasis, even if the pain is mild or moderate. So because it lowers the seizure threshold. The dose limiting side effect is nausea. It can cause a tremendous amount of nausea. So we need to give an a drug, an antiemetic along with this, like we do in morphine too. Next slide, please. Then besides morphine, the other step 3 opioid that's available for us is fentanyl. We can get intravenous, transdermal, and the oral transmucosal. Somehow we don't get the oral transmucosal here. I don't know where we get it, though it used to be available in the past as lollipops. It's a lipophilic drug. The preparations that we use mainly are the transdermal fentanyl and sometimes the intravenous fentanyl in the hospice setting. Next slide, please. So what is this patch? A lot of times patients are directly put on a transdermal fentanyl patch. So when we talk about fentanyl patch, it forms a subcutaneous depot of the drug. It takes about 12 hours for the analgesia effect to start. So it's not like you stick the patch and the next minute you're pain-free. It's not like that at all. So there are a lot of indications. The way we usually start a fentanyl patch is first, we ascertain the dose of opioid, which means we first need to know how much morphine this patient takes in a day to get pain relief. Based on that, we choose the fentanyl patch. So it's usually 1/3. So if the patient is taking, say, 60 milligram of morphine every day, then we need to choose a patch which is closer to 20. So depending on that, we choose the patch closer to 20, which could be 25, which is a little on the higher side. 12 might be too low because the different patch strengths that we get in fentanyl are 12, 25, and 50. So these are the patches which are commonly available. So first you need to ascertain the daily dose. Based on that, on the daily dose of morphine, you then have to decide the closest fentanyl dose. Once that is done, and then you apply the fentanyl patch, what we tell the patient is that for the first 12 hours, the medicine will not act. So please continue your morphine or whatever drug that you were taking for the first 12 hours. Only after that, the medicine is going to start acting. And then it's going to work for 72 hours. So this part of, and always tell them about the SOS dosing along with the patch. If you put the patch, it doesn't mean that you cannot take the SOS dosing. You will need the SOS dosing. And again, after 2 to 3 days, you might need to even retitrate. So fentanyl is good. It has its place whenever there is severe kidney failure, when you have a patient with intestinal obstruction and you need a transdermal route, when the patient is vomiting really badly, when the patient has so much constipation to morphine that you really have to change the opioid. But there are a few areas of caution. If a patient is very cachexic, you might never form that. You need some amount of body fat. You might never be able to form that subcutaneous depot. So fentanyl may not be a good choice at all. When the patient is febrile, fentanyl may not be a good choice. It might just take, come off and fall off. And whenever there is unstable pain, when the pain is spiking, coming down, when you're sending the patient for radiation to control the pain, whenever the pain is not stable, it is not a suitable drug. Next slide, please. Buprenorphine is another patch that I see very, very commonly being used. And somehow we don't use it. I'm sure Dr. Sunil can also tell us. But in palliative care, I hardly ever use buprenorphine because one is it has a ceiling dose. And second thing is I don't, you can't really titrate it along with morphine. And of course, it's frightfully expensive. But it does have its merits when a patient has renal failure. But because of the ceiling dose that it has, it kind of is difficult for us in palliative care. We hardly ever use it. But yes, I do see a lot of them with post-surgical pain taking buprenorphine. Maybe it's really helpful for them. Next slide, please. So when we talk of how do we decide doses, we always go with morphine as the base dose. So we decide everything based on the dose of morphine. So when we talk of equipotent doses, we say codeine is 1/10 potent. This is potency. And tramadol is 1/5 oral, 1/10 parenteral. And when we talk of oral, subcutaneous, and intravenous morphine, it is 1:1:2:1:3, which means you have to halve the oral dose when you give it subcutaneously. You have to make that dose 1/3 when you give it intravenously. So suppose you are converting a patient with 60 milligram of morphine requirement per day to the subcutaneous route, you will make it 30 milligram per day. If you are making the 60 milligram per day oral dose into the intravenous route, you will make it 20 milligram per day. Next slide, please. So what we mean by potency is different from what we mean by the efficacy of the drug. So efficacy is the response. What do I feel after I take the drug? It is the maximum response which is induced by the active agent. So the degree of analgesia following dose escalation limited by side effects is what we mean by efficacy. Whereas potency is a dose response relationship. So that is pharmacokinetics. How much of it is entering inside? How much is reaching the receptor? How much is getting attached to the receptor? How potent is the drug is the pharmacokinetics of the drug. Next slide, please. So that is why we base the classification of opioids as agonist, antagonist, and agonist-antagonist. And next slide, please. So when we talk of agonist means this drug has an affinity to this receptor and it will induce the changes in the cell, which will then stimulate the physiological activity. So they do not have a ceiling effect to analgesia, the agonist opioids. And that is the reason we don't need the body weight to start morphine. So what we do here is we keep on escalating the dose till you get a dose which gives them good analgesia, or you start getting dose limiting side effects. So that is this drug. That is the reason it does not have a ceiling effect. That is why it is the gold standard of in cancer pain or in chronic pain. Next slide. So this is what it means. As you increase the dose, the analgesic effects of the drug keep on increasing in a linear fashion. And as this increases, you either get excellent analgesia or you start getting adverse effects. When you start getting those adverse effects, you stop there. Or you have received an excellent analgesia, you stop there. Next slide, please. So all the agonists these are the drugs, and those in yellow are what we get. What we commonly use are morphine, fentanyl, and tramadol in our practice. Next slide, please. So what do we mean by antagonists? Now, antagonists are drugs which have no intrinsic pharmacological action, but it goes and interferes with that agonist. So they compete. They go and bind to those receptors. They compete for those receptor sites. Next slide, please. So these are the antagonists, and we use naloxone when we want to reverse the effects of morphine. Naltrexone is also used for constipation. Then we have some drugs which we call as agonist-antagonist. So this is where your buprenorphine and pentozocaine fall. So these drugs have a ceiling effect for analgesia. So though they can produce analgesia, they also produce withdrawal in patients who are dependent. And so that is why buprenorphine can be used for withdrawal, for drug addiction. Agonist at one receptor and antagonist at the other receptor. Next slide, please. So pentozocaine and buprenorphine. So what happens when you give buprenorphine? It has a low intrinsic activity. It has a ceiling effect. So you keep raising it. Beyond that, it will not help. And it will reduce the pharmacological action, when you administer this drug with morphine. So you can never titrate it along with morphine. You can never give SOS morphine and give buprenorphine. It really doesn't work well together. Next slide, please. So this is what an agonist-antagonist does. It brings down the action of your drug. Next slide. So this, when you talk about pentozocan, it has an agonist action at the kappa receptor and a weak antagonist action at the mu receptor. Now we know that morphine acts as a mu agonist. So that is why what will pentozocan do? It will go and replace morphine from these receptors. Next slide, please. So now coming back to the slide we left behind as to how we wanted to choose the opioid, we found that Mrs. X is on 50 milligram 4th hourly. You have these two choices of pentozocan and oral morphine. If you want to know how you manage, can someone give me the answer now? Would you like to continue and increase the dose with oral morphine, or would you want to give them an agonist-antagonist, which is pentozocan? Can anyone answer? Or have you all dozed off to sleep? Yeah.
Continue morphine.
Yeah, you have to give them extra morphine, and then you have to up titrate the morphine till you get a better response. You also have to ask them that on up titration of the morphine, are they getting pain relief or are they getting drowsy? So suppose they are getting drowsy and they are not getting pain relief, it means you have to go back, you have to reassess that pain. You might have to add another adjuvant or find out the cause for that pain. It could also be total pain. It could be a huge psychological element. It could be a element of distress in that pain. So you increase the morphine, look for the effect. If it works, well and good. But if the patient is drowsy without much effect, you have to go back and reassess. Now, this coming part to the second question with our patient, with Mrs. N, who's on mild to moderate pain, whom you have been taught that mild to moderate pain, we usually start with step 1, step 2 on the ladder. So would you like to give tramadol to this patient, even though she has moderate pain? So this is one instance where we will not give tramadol because there is a chance that it will lower the seizure threshold. So these are just a couple examples to tell you that choosing your opioid also goes with the basis of what are the other drugs that you already have. Next slide, please. So which brings us to what are the side effects with morphine. The side effect that you have to emphasize, re-emphasize, and keep re-emphasizing is constipation, because that is something which will never go away. And constipation should not be the reason for the patient stopping the medication. So do our best to give them the best to relieve constipation. Nausea, vomiting is a side effect which kind of goes away in a couple days, but always give them the right medication. Don't give them ondansetron. It will not help. It is better that we give them a haloperidol or metoclopramide to control the vomiting, which is due to the opioid. You can get some amount of sleepiness, tiredness, but that's again, it will go away in another 2-3 days. If the patient complains of itching, you might have to look into it. Sometimes it's self-limiting. Otherwise, you might have to, ondansetron is a good drug to add when they have itching. Dry mouth can come because of the effects of morphine. Urinary hesitancy. So when you prescribe it in the elderly, always ask for that history and go back to that history. Next slide, please. Constipation, like I said, choose the right laxative. Please do not just give lactulose blindly. It will not help. You have to give them a stimulant laxative and a stool softener. So bisacodyl, cramaphin with sodium picosulfate is a good choice. Next slide. Vomiting and nausea, it occurs in 1/3. Like I said, again, choose the right drug. Next slide. So this is the choice of drugs that you will have for nausea and vomiting. Next slide, please. And like I already mentioned, this can be self-limiting. Next slide, please. Now coming to the toxic effects. There are times when the patient will come to you, the relatives will come and say that something has changed. The patient is talking irrelevantly, or he's twitching in this really funny fashion, and they'll actually demonstrate the way he's twitching, or he's so drowsy that he's not able to get up. So now we are moving from side effects to what we call as toxicity with the drug. So opioids reduce respiratory depression. The answer to this is that please don't worry about respiratory depression when we give oral morphine to our patients, because we are increasing the doses gradually, and respiratory depression I mean, in all these patients, we've almost never seen it. Next slide, please. And when you have that kind of response, please look for something else. Look for a pulmonary embolism, a pneumonia, a pleural effusion, a cardiomyopathy, or whether you're giving him a benzodiazepine along with opioid, because many a times the patient is already taking it. You've not got it out in your history. So these are the things you need to worry about more. And about causing addiction. Today, you have a lot of patients who walk around with Google. And so the first thing they will find out is, you are giving me a drug that is going to cause addiction. And we have enough evidence to show that substance abuse as a result of medical use is low. The confusion is always between physical dependence of the drug and psychological dependence. When we talk of addiction, we talk of psychological dependence. Next slide, please. And we worry too much about the risk of addiction. So when we say addiction, it has to be a chronic neurobiological disease. It has a psychosocial element, environmental factors, genetic element to it. And this means that the person has absolutely no control over the drug use. It's compulsive and it continues despite causing him harm and causing craving. None of these do we see with our patients if we are able to titrate, explain, and treat them properly. Physical dependence is an adaptation. So when you withdraw the drug, the patient will go into withdrawal. So what happens is, we usually say, when you're down titrating your doses, like you may have patients who are going in for chemotherapy or going in for radiation, and after a point, you might have to come down on the doses. We do that very often because many a times patients get referred to us right in the beginning for pain, when the diagnosis is also not established, like maybe a pancreatic cancer, like maybe a bone tumor in an adolescent. These are very common places where we see the patient even before the histopathological diagnosis. So many times we start the patient already on opioids, and slowly, when disease-modifying therapy is given, when chemotherapy is started, when radiation is given, pain starts coming down. So we gradually taper the dose and take them even off morphine. And in non-cancer pain, you can have adverse events, but serious adverse events are rare. And I don't think I have too much experience with chronic non-cancer pain and opioids, but this is more in the Western world or in centers which use it. So even there, we have not really seen complaints because of addiction. Next slide, please. So this is the cost. And you can see from here how inexpensive morphine is. Next slide, please. Just one slide on methadone, because it's a drug which has been introduced in India recently. It's a synthetic opioid. The indications for use are morphine toxicity, complex pain when you have a mixture of different kinds of pain, renal failure. It's one place where it really helps, but it is not as straight as fentanyl and tramadol conversions into morphine. So the conversions are not, the opioid equivalence is not so easy. So dose titration takes training, it takes time. There are also certain drug interactions with methadone that we need to be concerned about, electrolyte disturbances, and there could be some fatal side effects. But having said that if we train to use this drug properly, it can be a huge asset because it's even cheaper. And in fact, as the doses of morphine are higher, we start with the lower doses of methadone. Next slide, please. So with this, I'd like to conclude that suppose a patient is on 30 milligram of morphine 4th hourly. What is his morphine daily dose? Any answers? Can you all shout? Very, very simple. 30 milligram Q4 hourly.
180.
30 into 180 milligram.
180.
So, yes. So how would you convert this into SR morphine? So SR is your sustained release morphine. How would you like to give it? So you could work on the math. If you want to do it as an SR, you have to give it every, so say, So 90 milligram twice in a day.
So 180 divided by 2, 90.
90, 12th hourly. And suppose you need to switch this patient to transdermal fentanyl. What will you do? 60. So the closest dose will be. So you just divide it by 3 for simplicity, and then you will get a dose of 60 milligram. The closest dose would be 50 of fentanyl. You start with a 50 microgram patch, and then you can add SOS doses and slowly escalate. And if you need to have it as a subcutaneous or an intravenous route, what would you do? 1/2, so 180/2. Yeah. We have an intern here, so she's busy answering all the questions, which is really nice to hear. So I think I'm done, Rajlakshmi. Now, those who are sleeping, please wake up. And it's time for questions.
Thank you, Dr. Vidya, for this detailed session on opioids. So I think anybody has any doubts, please ask.
Dr. Sunil, please feel free to add anything that I must have missed out.
No, you haven't missed anything. So we will go for questions and then we can summarize the session. Anybody?
No questions means that you haven't understood anything or that you're too well versed with morphine. So both of which are dangerous.
So please feel free to ask questions. So how many of you use morphine? Just raise your hands. Dr. Anshika?
Morphine and fentanyl.
Sorry? Dr.
Morphine and fentanyl are used.
Okay. Thank you.
So we are using morphine quite regularly, and I can say since before we were using morphine, the patients really thank you, and once they start taking morphine and the analgesia is adequate, they always come back and thank you. The relatives would come back and thank you. The only problem is that in the state of Uttarakhand, it is available in very few places.
Dr. Anshika, do you have a particular story to share about a patient when you started patient on morphine?
Multiple times in the OPD, the relative would come back after for the second or third prescription, and they'll try to touch your feet and say thank you. And initially in the beginning you feel a little strange, and now you already know that they are about to do the same, like touch your feet and say thank you. That is the amount of relief they have felt, and they come and say, now she's sleeping after 3 months, now is the time that she has started sleeping at night. Thank you, doctor. So this is so of course morphine is a great addition to the your prescription. Only problem is in a state like Uttarakhand, because of the hilly terrain, it's difficult for the patient to keep coming back for the prescription. So that's the only thing, but definitely very helpful.
Thank you, Dr. Anshika. Anybody else? Anybody?
Hello,
Yeah,
doctor. I'm just asking many of the patients to go to biotechnology where they are studying, doing yoga and pranayama. Most of them are very happy. What is your opinion about it?
Okay. So anybody has done any research on yoga or pranayama for pain management? Anybody has any experience or are they practicing? Anybody has any opinion?
Sir, in our institute, we did, there was a nurse who was doing her PhD. So she did on patients who are receiving chemotherapy for breast cancer. So they would receive 6 or 8 cycles. So she started with breathing exercises like pranayama and other yoga. And she looked at their stress levels, not the pain. They looked at the stress levels and distress. And she proved it. It was a randomized control trial. Half the patients were given yoga and half were not given. And they proved that the stress levels were low in this group of patients. So, but she didn't do it on pain.
Vidya,
See, pranayam, this is something, at least the deep breathing exercises is one thing we tell regularly to all our patients with lung cancer. They come to us really early. So we give them morphine, but at the same time, I teach them pursed lip breathing and deep breathing. So and I mean, why we do this is because when they get really dyspneic later on, it becomes easier to manage. So that I have seen is really beneficial because you can't train them when they are breathless. So we start training them early with these breathing exercises. But and I think there was a whole section about yoga in IJPC, right, Dr. Sunil?
I have seen some articles, but I'm not sure what was the inference from those articles. So might be
It's more like an adjuvant. Instead of calling it a substitute, it works well together. So when you're giving the patient medication and also telling them this, works well together. That's very little experience that I have.
so it's a type of non-pharmacological pain management. So in addition to the pharmacological management, you can try with those things, but I don't know how much evidence it has. But maybe it might be working by many mechanisms. One of those might be distraction techniques, and there will be many other mechanism also. But usually it is not the primary mechanism, primary thing which we advise to the patient, but definitely as an add-on therapy. Okay. Anybody else? Okay, if there is no question, I would like to summarize the topic, the session that Vidya covered now. So, a strong opioids or opioids for moderate to severe pain, that's the more correct term. And there are three opioids available in India: morphine, fentanyl, and methadone. Um, so morphine is the gold standard for pain management in that step everywhere in the world. Morphine is when you take morphine orally, it goes to GIT. It gets absorbed from the upper small intestine, and goes to the portal vein to the liver, where it gets metabolized, and it is converted into two components mainly, M6G, and that is morphine 6 glucuronide and morphine 3 glucuronide. And you have to understand that the component which give you pain relief is M6G, which is formed in less quantity, that is about 5 to 15%. So the M6G is the component which will give you the pain relief, and it will the morphine and its metabolites will be excreted from the body by glomerular filtration. So when the patient has renal failure, you have to reduce the dose, and instead of 4-hourly frequency, you might increase it to maybe 8-hourly, 6-hourly, or 12-hourly, or even once a day, depending on the serum creatinine. And morphine can be used as an analgesic, as a cough suppressant for breathlessness, and also for treating diarrhea which doesn't have any specific cause. Then fentanyl has to be used in patients whose pain is stabilized. So when the patient is taking when the patient has pain which goes rapidly up and coming down many times a day, in such patients fentanyl is not suitable, because the fentanyl patch, the strength 12.5 or 25, which indicates that those much amount of fentanyl is released every hour. So the amount cannot be varied. So that's why fentanyl patch is not suitable for a patient whose pain is not stabilized. And it is also costly compared to morphine and other medications. Methadone is a good opioid which is available now in India. But what you have to understand is it has many interactions with many medications that we commonly use. But it has multiple mechanisms of action, like it acts on all the opioid receptors, mu, kappa, and delta. And it also has tricyclic like action. It also acts as an NMDA antagonist. So because of three actions, it has a good effect on pains which are predominantly neuropathic pain. Uh, and it is also a good choice of opioid in patients who are having renal failure. Um, but the Dr. Vidya talked about the potency of various opioids, but methadone doesn't have linear relationship in terms of potency. The potency varies as per the dose of morphine, so that's also another important factor. And methadone will take about 5 days to 7 days to get the blood level stabilized. So we have to we need to be careful, because usually when we titrate morphine, we can even titrate increase the dose of morphine every day, but methadone is not like that. So there are many things which need to be taken care while you start a patient on methadone. The mixed agonist antagonist like pentosocin or partial agonist like buprenorphine doesn't have much role in chronic pain management. But for those who for those morphine is not available, then in such states maybe those might be used. So that's a brief summary about Dr. Vidya's session, and let's move on to patient story. Anshika has raised. Dr. Anshika, do you want to ask anything?
Sir, I wanted to ask about sublingual morphine tablets. Where is the role of that one? Sublingual, buprenorphine, sorry. Buprenorphine.
I don't have any experience with sublingual buprenorphine. Vidya, do you have? Please unmute me.
Honestly, I hate buprenorphine because I only see the patch. But sublingual buprenorphine, if I'm not mistaken, is only for de-addiction, and we are not supposed to give it for pain, is what I have heard, which has been spoken, that it has been used for de-addiction and it's not licensed for the use of pain. So this is what I have heard. So, we really hard. We don't use buprenorphine at all. I mean, almost never. Though I do have some patches for the surgery, people use it. And as far as sublingual, this is the information I have. But we can definitely find out and let you know if there is anything more.
Okay, thank you, Vidya.
So I hope we can move on to our case presentation. We can move on to our case presentation. Dr. Shobha, can you hear us?
Yeah.
Yeah.
Hear you.
Ma'am, I hope you can see your screen too.
Yeah.
Okay.
Yeah.
You can start, ma'am.
Am I audible?
Yes, you are.
I am audible. Okay. Fine. Good evening. I am Dr. P. Shobha. I am a family medicine specialist at VTS Lakeshore Hospital in Kochi. Yeah. Can I have the first slide, please? Yeah. So this patient is Mrs. X, a 57-year-old lady who has been diagnosed with carcinoma of the right breast, and in 2008. And this was found to be infiltrating ductal duct carcinoma, staging P T2N2M0. And she had undergone white lump excision and axillary lymph node dissection in 2008, followed with adjuvant radiotherapy and chemotherapy. But she was found to have progressive metastatic disease in 2013 with bone and liver mets. Along with, she was given multiple cycles of chemotherapy, and later on she developed lower limb flexopathy of left lower limb more than right, and chemotherapy-induced hyperglycemia, and neutropenia and thrombocytopenia. And now she's presented with complaints of pain over both hips and thighs, left lower limb more than right since a year. She is also having mucosal ulcerations, constipation, drowsiness, and she was detected to have hyperglycemia in May 2019 following chemotherapy, especially with steroids, and detected to have neutropenia, thrombocytopenia recently due to maybe bone marrow infiltration or chemotherapy induced. Next slide, yes, thank you. Coming to the history of illness, Mrs. X was diagnosed to have CAF right breast in 2008 and underwent a wide excision with axillary lymph node dissection. HPR showed infiltrating duct carcinoma grade 2, and staging done was T2N2M0. Immunocytochemistry showed ER positive, PR positive, and ER negative, PR positive, and HER2 negative. And she was given chemotherapy with paclitaxel, FEC, followed by radiotherapy and hormonal therapy also, that is tamoxifen, till 2013. She later developed low backache in 2013. MRI showed vertebral mets. PT-CT was done, which showed metabolically active multiple skeletal lesions, especially of the right iliac bone, multiple vertebral levels, and ribs. And this is suggestive of extensive bony mets. She was started on further chemotherapy and also monthly zoledronate. Repeat PET-CT initially showed good response, and she was started on tab letrozole. But later PET-CT showed again further newer lesions, again suggestive of disease progression. Started on denosumab, and also the last PET-CT she had multiple new skeletal lesions along with liver mets, and started on paclitaxel and carboplatin in April 2018. This chemotherapy was continued till July 2018, and she was also continued on denosumab injections monthly. She was later started on capecitabine as well as letrozole was continued, and chemotherapy was continued also with the eribulin. The first one was given this month on 8th, and she was also given GCSF on 8th to counter neutropenia. Radiotherapy was given to bilateral femora. On examination, vitals are stable. There is right arm edema present. Oral mucosal ulcerations are also present. Pain score on admission was 4/10. Next slide, please. Yeah. And the investigations showed anemia. Hemoglobin was 7.5, which improved to 8.2 gram%. Total count was 14,000 cells per millimeter cube, which improved to 13,960 cells. Neutrophils were only 15 per 50 cells, but later on that improved to 64%. Platelets were 40,000 cells per millimeter cube, which improved to 46,000. And creatinine was stable at 0.5 milligram%. Liver enzymes were also slightly elevated. RBS was found to be 310 milligram%. While on admission, she was on treatment with tab gemcitabine once a week, and also for pain, she was on Ultracet and Calpol. She was taking SOS 500 milligrams. She was also being given tab Lyrica 150 milligrams HS, tab Certa 50 milligram HS, and also other supportives along with the calcium tablets, and also on OHS. Next slide, please, ma'am. Coming to the psychosocial aspect, basically she has been having this since 2008, and she has kind of accepted the situation because of the long duration. But financially, they are well settled. She is a teacher. Husband is also an engineer. So that is it. Next slide, yeah. After on admission here to our hospital, she was started on insulin along with Grafil, injection Grafil, which was increased from 300 to 375 milligrams. And also antibiotic tab Ciplox was started along with the pregabalin 75 milligram HS. Vislon was also given 20 milligrams 1/2 of 5 days, along with the mucin gel for oral application, and mucin gel as well as chlorhexidine mouthwash for oral application. Ceftriaxone was there, 15 milligram TID, and tab Gerpisa was given 10 milligram HS. And also she was given leukoplatelets and 1 pint of Paxil, and continued on neutropenic care and diabetic diet. And for pain, she was started on fentanyl patch, 100 microgram per hour. That was there given in another hospital. We started on about 25 micrograms per hour patch. And with this, she was having constipation, drowsiness, all those symptoms improved. And tap morphine, which was there for SOS, 5 milligram fourth hourly, she didn't take. There was no need for her to take that. And in her case, the main concern is basically regarding her children. Both are grown up, but daughter is studying as a final year student, and son is employed but not married. So she was a little bit worried about that aspect. And in summary, this is Mrs. X, who is a 57-year-old lady. He was admitted on 13th of this month. Status post breast conservation surgery in 2008, followed by adjuvant chemotherapy and radiotherapy. She has been admitted with various symptoms and signs like constipation, drowsiness, and neutropenia, thrombocytopenia, which improved with the treatment given. And there was improvement in other symptoms like drowsiness, lethargy, lower limb pain, and sleep is also adequate because she was not feeling pain at night. And main thing is we have to find out whether the neutropenia is due to chemotherapy or is it because of the bone marrow infiltration. And she has been planned to have a bone marrow biopsy and to undergo further chemotherapy as the findings. But improvement in symptoms has occurred with the less use of dose of opioids in the past few days.
Okay. Thank you, Dr. Shobha.
Thank you, sir. Thank you so much.
I think we have experts to talk regarding the neutropenia. In this group, we have many oncologists. So I think Dr. Gaurav, are you there?
Yes, sir, I'm there.
Okay. So can you comment on the first point? Due to neutropenia is due to chemotherapy and or bone marrow infiltration.
I wouldn't like to comment on every point of the treatment. It's a bit haphazard.
Okay.
Firstly, secondly, what could have happened is, yes, she could have some bone marrow infiltration, but again, then for that you need to get a bone marrow proper biopsy and then comment on that. So, and secondly, actually, I wouldn't have started this patient on a chemotherapy in a way which was done. Like she has got disease which was initially confined to the bones, and that should have warranted a hormonal therapy. Actually, that would be much better and safer for the patient. So that is that, and possibly it could be chemotherapy-induced neutropenia. It could also be due to the bone marrow infiltration because of the disease, or and yes, also there is the radiation which is given to the hip joint and the pelvis. So that could possibly be one reason why she has this neutropenia.
Okay. Thank you, Dr. Gaurav. Anybody else want to comment on the first point?
Hello? Hello?
Hello, Dr. Gaurav?
Yes. Yes, I can hear you.
Yeah. No, I was asking if there is anybody else who want to comment on the first point.
Okay. What was the first point actually?
It was the neutropenia due to chemotherapy or due to bone marrow filtration?
Okay.
Dr. Shobha, you wish to add something?
Actually, we are more in favor of bone marrow infiltration because but the biopsy is being awaited. So that is the idea.
Okay. Dr. Shobha, do you want to what would you like to discuss regarding Broman symptoms with the less dose of opioid? Is that a question or a statement?
No, that was a statement only because she was actually having constipation and drowsiness because they had given 100 microgram per hour fentanyl patch. So with that, she was lethargic and she was feeling tired out. So once we adjusted the dose to about 25 and along with the other symptomatic management, she was quite happy with that. Like her constipation resolved. She was able to sleep adequately. So that was seen with the patient. So we had to give only less dose. But today she was having a little bit of an itching. And the patch was again reduced to 12.5, the half one.
Okay.
I have a question.
Yes. Yeah.
I have a couple questions. One is to Dr. Shobha.
Yes,
what was the, because like disease protocols are usually evidence-based protocols, right? So
yes,
especially in view of now doing the foundation course and learning about this,
yes, ma'am.
do you consider any other way in which you would have started the opioids for this patient rather than starting with randomly starting with, I mean, someone else started the 100 mg and then you
Yes.
brought it down to 25 mg and now you're going to make it 12.5 mg.
Yes, ma'am.
Is would you like would you think of some change in your own practice of sessions, because it's rather dangerous. We've seen patients collapsing with 50 mg fentanyl just without opioid titration. So
Yes,
is there a way that you can introduce this at your center by saying that unless we titrate opioids and have the evidence base for fentanyl, why should we start it just because the patient has money? I mean, that's a question, because not a question, it's just a thought, because why wouldn't we start this patient on oral morphine, steadily increase, give her a good SOS dosing whenever she has breakthrough pain, which will actually help her.
Yes,
And if she has dose limiting side effects, then consider fentanyl. So would that be a thought? I mean, I just wanted to ask.
Yes, ma'am. Yes, ma'am. Surely, ma'am. Actually, previously we have given morphine for the breakthrough, but pain and all, but she was not taking that. And I think maybe the other center started the fentanyl because she was affordable. I mean, they were quite affordable.
Yeah,
I
this
think
is
that was
exactly
only
what I wanted to bring about, because we need to have certain ethical guidelines to follow.
yes,
Though you
yes.
can afford fentanyl, it doesn't mean that you have to put it to every patient who can afford. And
Yes,
Gaurav and the oncologist, just one more question. I saw denosumab being used. That is one of those rank ligand inhibitors, like the bisphosphonates. Is there any particular basis on which we change from zoledronic acid to denosumab? Or because yes, I know that they are less hurtful to the kidneys, but her creatinine is normal. So again, is it only because she can afford the drug that it was changed from a cheaper zoledronic acid? And I also know that yes, this is a subcutaneous route. But is there any particular reason for which it could be changed? Any of the oncologists? And one more question was, why are you giving her Vice alone, especially when she's diabetic?
I think it was as an adjuvant only, ma'am.
For what? Vice alone 20 milligram adjuvant for what?
Maybe because of that only she is having
I see the Lyrica at 150 milligram OD somewhere. Here I saw Pregabalin 75 OD, and there is also a gabapentin. I saw gabapentin somewhere, I think, which is again a combination. So
yes, ma'am. Other center they had given.
Like we usually say in neuropathic pain, don't kangaroo between it between the medications. Steadily increase one, and then go to the then add on. I mean, those are a little those prescriptions looked a bit of Dr. Sunil, what do you think?
Yeah, the questions you asked are relevant. Regarding the first one, starting on straight away on fentanyl patch. So in this patients, it was started from somewhere else, but when she became drowsy and became constipated, if I was the person, I would have stopped it and might have started on something else depending on the pain score. And for neuropathic pain, which we already discussed in the previous class, did we? So, in case of neuropathic pain, you know that pregabalin and gabapentin are very much costly, and we have less costlier options like sodium valproate or imipramine, amitriptyline. So, all those are less cheaper options, and as Dr. Vidya told, we usually start with either with the tricyclic antidepressants or with anti-epileptic medication and titrate it up to the maximum dose. So in case of tricyclic antidepressant like amitriptyline, you can titrate it up to 75 to 100 milligram. And then only you add with another anti-epileptic medications like sodium valproate, any other medication. Um, so, uh, so pharmacoeconomics is very much important for patients because many patients whom we saw, they will keep coming to us telling that their symptoms are not getting under control. So one of the reason might be they are not taking the medicines properly as we prescribe because pregabalin and gabapentin, all those will cost very high. So they may not be taking it at all. So that's another problem. And Vicelon, I don't know whether it was added for bone pain or something else. um, so Dr. Anshila?
Sir, I wanted to just talk about the cost of treatment, whether it is a paying patient who is affordable, or it is a insured patient from CGHS, etc., or it is a patient who's poor self-payment. So there are direct cost and indirect cost. In this patient, we can see there is a lot of direct cost of treatment. Even if she may be affordable, or she may be, a panel patient, but somebody is paying for it. And we have to decide the cost of treatment over time, over whether that money can be saved for something else by the family. And so in this patient, we can see the amount of chemo and hormone therapy and other different drugs which have been given. So although it has been started by some other center, the whole treatment has been given by some other center. But as palliative care physicians, we can start discussing with the patient this aspect, the financial aspect as well. Because if the patient does not know that this medicine is not necessary for them, they feel that this medicine is very important. If they don't take it, then there'll be some problems. So at least as a palliative care physician, we can discuss the cost of the treatment versus the benefit with the patient sometimes.
Okay, thank you, Dr. Anshika. I think Dr. Vidya asked one question regarding folic acid and denosumab. So some of you can answer that question.
My only question
Ma'am, regarding
is
this,
there a particular indication that we give denosumab over zoledronic acid? Because that was one. And doesn't eribulin also cause bone marrow depression? When you
ma'am, I'm a surgical oncologist, so I don't think I'm. I should be asked this question. But I can see a lot of drugs which we don't use.
Dr. Gaurav?
I was actually waiting, like denosumab, actually we offer it upfront to people who have bone mets. We offer it upfront. The reason being, the skeletal free events, means the patient does not have osteopenia or bone pain or bone fractures, that has found to be significantly much better with denosumab. Now denosumab is also a very expensive drug. So we discuss all options. We tell the people if they are insured, they should go for it. If they are not insured, I think they can stick with zoledronate or alendronate. Both will do. So osteocal or zoledronate, both are equally good options. But if we have to offer your denosumab, I think it should be rather we should offer this option upfront. So that is one thing.
Okay.
And I think it causes more hypocalcemia, no?
Yeah. So that's why we always keep checking the calcium levels.
And again, adding to our, because most of our patients are on Zol and they're quite, but I just want to know what's the evidence base. So
no, it's there. It's there. The evidence is there, but the bigger question is the cost. So if the patient has to bear it, then I think we rather do away. 99% of our patients get zoledronate or alendronate. Even denosumab is mostly for textbooks.
Um, so, anybody else have any comments on this patient? Those who has not spoken yet. Okay, if there are no questions, I would like, yeah. Who is speaking? And
sir, I just wanted to,
yeah.
sir, this is Dr. Anshika. I just wanted to again just emphasize on constipation with opioids, that as ma'am very well said, that patient should not stop the opioids due to constipation. So one hand which writes morphine should write something for the constipation at the same time, and syrup loose or lactulose is not going to do it. So we have to make sure that we write something for constipation with the morphine, and we write with it, not in on a separate page, because patient does not understand why these medicines are written together. So that's very important.
Okay, thank you for that point, Dr. Anshika.
Yeah, very rightly said, and something which it's a disservice if we don't do that. So, thank you very much, Dr. Sunil. It was really nice, and all of you participants also. It was fun being with all of you.
So some of the points which we discussed was one thing was don't start straight away on fentanyl patch in a patient who we are seeing for the first time. So only stabilize the pain with morphine, and then if the pain is stabilized, then you convert it into the corresponding fentanyl patch. Then we discussed about whether vice loan was needed or not. Then there was what was the reason for neutropenia? Was it due to bone marrow infiltration or chemotherapy induced, or even radiation was also a contributory factor? So they have already taken bone marrow biopsy, and most probably that will also give us some clue into the question. Then there was a healthy discussion regarding zoledronic acid versus other bisphosphonates. Um, um, then the neuropathic pain treatment with tricyclic antidepressants and anti-epileptic medications. So whenever we prescribe, we should also look into the cost of the medication. Um, so I think these are the points that we discussed. So thank you, Dr. Vidya, for joining us and for taking this session. And thank you all for joining today's session. And our next session will be on next Wednesday.
Topic medical ethics taken by Rajagopal sir. Thank you Vidya ma'am and thank you Shobha ma'am.
Thank you all.
See you with another session. See you on Wednesday. Bye.
Hope everybody will speak in the next session.